Lots of information. There we go. Okay. All right. Well, it is really nice to see all of your faces. I'm so glad you could join. So let's go ahead and get started. There is a lot of information. I would ask you all to mute yourselves, please. And if you have questions along the way, write them down and we'll answer them at the end, because I may wind up answering them as we go along anyway, but there is a lot of information. All right, so you know me. I may, just to refresh your memory, I'm a ex-Navy doctor, retired family physician with 20 years of experience and about 15 years experience in the design and management of epidemiology studies. I live with my husband and dog here in Milton on Blackwater Bay since 2008, and I've been a member of the church since last year. All right, so why this talk? Because it's hard to believe, but we are now 5 months into experiencing the most significant medical crisis since the Spanish flu pandemic of 1918. There's a daily deluge of overwhelming amounts of media reports and misinformation about the virus, and so it really is hard to know who or what to believe. So hopefully I can help with some of that tonight. Well, you know, if you look at the guy on the left, and I'm sure many of you recognize him, this was us back in early March. We were like total disbelief. This was all your faces when I got up in the front of church that day and told you what was going to be happening. And we went quickly into a mix of emotions. I know I did, stress and depression and grief over losing our way of life. And then after about a month of that, I went into just intense rage and anger, and then back again. And I'm sure many of you feel the same way. Now, I know Nancy is going to be talking about emotions and COVID. Is it next week, maybe? So I'm not going to talk about that, but just to let you know that it's perfectly understandable why we feel that way. Because if you look at the numbers, and these are pretty current numbers, almost 4 million cases in the United States, 3.8 million, over 140,000 deaths. And if you look at the graph of cases, it's just been a roller coaster ride, and it's just a lot to take in. So many of us do this, and I quite frankly find this way of dealing with problems very useful many times. So I do that for a while, and I did that for a while with this. But honestly, I feel like really the truth is really what sets you free. And so the way I deal with these kinds of things is I want data, I want knowledge. I want to know if the news is bad, I want to know the truth about it. I don't want things hidden from me. So for tonight, that's what I want to do, is I want to talk about what we know, what we don't know, you know, what we've learned. We still have a long way to go, and we'll talk about that. It's been quite the journey, but we are learning a lot. So let's start with the demographics and disease course of this disease. As you probably know, the virus is a member of the coronavirus family. Now, we wish it only caused the common cold, as other coronaviruses do, but it is in the same family as the severe acute respiratory syndrome, or SARS, and Middle East respiratory syndrome, or MERS. This is a novel new coronavirus, and it was discovered in December 2019 in China. Now, the virus was named the Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2. You really don't see that too much. It is the disease that we're more familiar with that was named COVID-19 because it started in 2019. So you'll hear me just refer to COVID through most of this talk. Now, when we first learned about this disease, the first question on our minds was, how deadly is it? Because God help us if it was going to be as deadly as Ebola, and thank heavens we learned pretty quickly that wasn't the case. Ebola, as you can see here, kills 50% of people it infects. But we were quite concerned because this novel new coronavirus is in the same family as MERS and SARS. And as you can see, there are no slouches when it comes to their fatality rates. So MERS kills 34% of infected cases, and SARS kills about 10%. So that's very, very concerning if COVID-19 has that kind of fatality rate. What we found fairly early on coming out of China and Europe was that the case fatality rate was much lower, was about 3.4%. Currently, as of yesterday, the case fatality rate here in the US is 3.7%, and it is decreasing because we do estimate that at the end of the day, when this is in our rearview mirror, the estimated case fatality rate will be 1%. And right now it's about 3.7%, but it is coming down. The more people we test, the more people who survive the disease, the lower the case fatality rate goes. And just for comparison's sake, you can see there the case fatality rates of measles and the flu, the good old flu that we see every winter, which has a case fatality rate of 0.1. So even if we get down to 1%, COVID-19 is at least 10 times more fatal than the flu. So don't let anybody tell you differently. This is a chart of the risk of COVID severity by age. And this data is from Florida and it's current as of today. Now, COVID, and we learned pretty early on that COVID, attacks can certainly attack everybody, but that the worst cases, the hospitalizations and the deaths, occur in older people, as people age. So I'm trying to find my, oh, here we go, my laser pointer. There we go. So you can see that the peak of the cases is in the younger age group, and that definitely became more so during this kind of upswing that we took over the last month. But that hospitalizations here are as people age, and then of course people 85 and older have 75 and older have a much higher problems. There is a gender breakdown. It's fairly even. Females right now have 51% of the cases, but a couple months ago when I was doing these presentations, it was even 50-50. We also learned early on about the incubation period of COVID, and the incubation period is how long it takes someone from exposure to show symptoms. The median time is 4 to 5 days from exposure to symptom onset. So half the people will start showing symptoms within that period of time if they're going to show symptoms.
4 to 5 days.
4 to 5 days. It extends to 14 days, and one study actually reported that 97.5% of people develop symptoms within 11.5 days. So we're pretty certain 14 days covers the full 99.9999% of people. Now, this length of the incubation period is actually quite long, and it certainly is a major factor in the disease's high rate of infectiousness, which we're going to talk about more in detail. Just for comparison, the flu's incubation period is only 1 to 4 days. So the fact that people are walking around for a long time before showing symptoms is definitely a problem with this disease. We also learned early on about the clinical severity of COVID. Thankfully, the vast majority of people have mild to moderate symptoms that are usually managed at home. About 81% of people. Now, don't get me wrong, some people have literally just the sniffles or a little bit of a sore throat or achiness, but these people also include those people who are literally have mild pneumonia, are running fevers for 10 days, can barely walk from their bed to the bathroom. They just don't need to be necessarily on oxygen in the hospital. So this category of mild to moderate is actually quite large. And I think we'll see a breakdown of this at some point in the future. Severe cases are about 14%, and these are people who need to be managed in the hospital. They don't necessarily need the ICU, but they need oxygen. They need close monitoring. Their x-rays might show more than 50% lung involvement, and it's just too dangerous for them to be at home. The median time from exposure to hospitalization is about 7 to 10 days. Critically ill patients are those who need the ICU, and they're typically in respiratory failure. They may need a ventilator. They may go into shock or multi-organ system dysfunction. The median time from exposure to ICU admission is about 10 to 12 days, and unfortunately, the mortality rate in the ICU is still very high, 39 to 72%. of cases in the ICU don't make it out. We also knew very early on that people with pre-existing conditions are more at risk. So age is a factor, but when you're even if you're younger, pre-existing conditions are important. And so this is a chart. It's back from May in U.S. hospitalizations, and the blue bars are adults. The green bars are in pediatric cases. And you can see that the blue bars are what we typically see in pre-existing conditions, cardiovascular disease, hypertension, diabetes, kidney disease. And you see this almost 50% here of obesity. Well, in pediatric cases, you also see cases with pre-existing conditions, though here 45% of cases have no pre-existing condition in children, and almost half of children have obesity as a pre-existing condition. Now, I remember hearing way back in the beginning an epidemiologist talk about the fact that what we were seeing in pre-existing conditions and people being hospitalized in China and Europe was going to be very different than what we see here in the US, and that has turned out very much to be true because of the obesity prevalence that we have in our country. In fact, obesity has turned out to be the most common risk factor for hospitalization in people less than age 55 years old. And just at the end of last month, the CDC had it linked with all of these severe illnesses on the left: heart failure, coronary artery disease, chronic lung disease, having an organ transplant, diabetes, kidney failure, sickle cell, and obesity were all listed as being those diseases that place people at the highest risk of severity and death when admitted to the hospital. So it's a big concern, and I always take it with a grain of salt when I hear people talk or see on the news that somebody got very sick or died and had no pre-existing conditions. Usually when they show the picture, it's somebody who's quite overweight. And I tell you this as a mother of a 30-year-old who's in this category, and it scares me to death. Race and ethnicity is something you've probably heard about. There's definitely disparities when it comes to race and ethnicity. Here in Florida, we have about 77% white, 17% African American, almost 26% Hispanic or Latino of any race. But when you look at the breakdown, and again, this is current data as of today, in Hispanics, they have 32% are hospitalized. So that's higher than their makeup, so it's disproportionately higher than what it should be, as is the Black population with hospitalizations and deaths. It's much higher than their proportion in the population. So why these disparities? Well, it's something we know, unfortunately, all too well. Certainly there's a high prevalence of pre-existing medical conditions in Black and Brown communities. They live in more multi-generational households, so many people live together. They're unjustly overrepresented in the hotspots of jails and prisons and detention centers. They represent a high percentage of the service industry workers who've been out there right from the beginning, members of our nursing home and assisted living staffs, grocery clerks, postal carriers, the ag industry, bus drivers, etc. These are jobs that are more likely to lack paid sick leave or health insurance, and so they don't seek out health care as readily. Their jobs are more likely to be low wage, with greater inability, therefore, to afford health insurance copays. That can impede their access to health care. Workers are more likely to use public transportation to access jobs, and public transportation has been a huge problem with transmitting the disease. Also, unfortunately, there's been long histories of medical bias in healthcare in general prior to the pandemic. But during the pandemic, we do hear anecdotal reports of Black and Brown people saying their symptoms were being dismissed, that they were refused tests, they were being discharged from the emergency room instead of being hospitalized, and then they get sicker when they come back. So reports like that. Systemic racism in general, as you know, contributes to lifetime ravages of chronic stress and immune suppression, and all of that has subsequent negative health effects and susceptibility to diseases. So this topic alone could be an entire presentation. And I know I'm preaching to the choir when it comes to saying that we need to rectify this situation. So let's talk about symptoms. We learned early on that symptoms included fever, cough, shortness of breath. We began to learn pretty early on that fatigue and anorexia and sputum production and myalgias or muscle aches and headache and sore throat, and nausea, vomiting, and diarrhea, all of these things can be presenting symptoms of COVID. But quite frankly, as physicians, these are what you see in every viral illness. These certainly are not unusual. What makes COVID extremely unusual is what we've learned as time has gone on with the development of symptoms from every organ system, quite frankly. Much of it related to vascular problems. We see arterial and venous blood clots. Some people have had to have leg amputations because of the arterial clots. People have pulmonary emboli. Many neurologic symptoms, including strokes, confusion, impaired consciousness, numbness and tingling, paralysis, delirium, hallucinations, loss of taste and smell that you've heard a lot about, abdominal pain, bowel infarctions where you lose blood supply to the bowel and the tissue dies, cardiovascular symptoms like angina, heart attacks, heart failure, dysrhythmias, liver and kidney dysfunction, skin rashes, the purple red toe syndrome, conjunctivitis. Every organ can be affected because every organ is vascularized. But we've also seen and realized that this disease is a problem with hyperinflammation that leads to activation of this blood clot pathway and arterial inflammation. And sometimes this hyperinflammation is relatively mild, it's not severe, and so we may only see the blue toe syndrome, or we may only see loss of taste and smell, something mild. People don't even need to go to the hospital. But sometimes that inflammation winds up galloping along, and we don't know the reason for that. We don't know why, but we start to see what's called a cytokine storm. Cytokines are inflammatory immunologic proteins, and they're supposed to help us fight infections, but they get short-circuited. And so we wind up seeing the body, every organ in the body essentially getting short-circuited, and wind up seeing bleeding and enlarged spleens and low blood counts and just all organs failing. And the cause is not known, and hopefully we'll find out someday. But there's no doubt that this hyperinflammation is part of what is part of this pediatric multi-system inflammatory syndrome that you've also heard about, with little kids wind up getting really sick with high fevers and inflammation and heart problems. That's really the major issue in this syndrome, is that children can develop aortic aneurysms similar to something called Kawasaki disease. So they need echocardiograms and to be watched very, very carefully. So far, there have been 14 cases in Florida as of today, ages 2 to 17. There have been none in Escambia County, however. Another set of patients I do want to talk about are the survivors of COVID, because we have many unanswered questions regarding survivors. And quite frankly, we're so busy trying to put out the forest fire, there's no time to really think about the people who are surviving this, sometimes with poor quality of life. And the reason that we're concerned is because, again, this virus is related to SARS. SARS caused an epidemic primarily in Asia back in 2003. And SARS has been studied a lot and since then, and the survivors, many of them have shown long-term suffering and very poor quality of life for well over 10 years. Poor lung function, poor immunity, susceptibility to new infections, chronic fatigue, higher incidence of cardiometabolic and neurologic disorders, inability to work again. So surviving the disease is good. But we still have a lot to learn about what it means to survive it. And given the prevalence, the sheer prevalence of this disease, we are going to see chronic health problems for many, many years, especially in our hospitalized survivors. And we're going to see a very heavy impact on our healthcare systems in the future. So be prepared to learn a lot more about that as time goes on. Now, infectiousness is really something that we have been learning a lot more about. And this started probably a couple months ago when we started to realize that this had a high asymptomatic transmission. You remember the USS Roosevelt, that Navy ship? We found more than 60% of the crew who tested positive were asymptomatic. We learned that Iceland, which tested 6% of its population, found that 43% of those who tested positive were asymptomatic. When New York was at the height of its cases, the labor and delivery wards were testing pregnant women as they came in a 2-week study of almost all pregnant women in 2 wards found that 88% of test positive patients had no symptoms whatsoever. And we found out through mass testing in some prisons early on that large numbers of inmates showed no symptoms whatsoever. In fact, in 4 states, 96% of over 3,000 inmates who tested positive were asymptomatic. So that began to give us a pause for concern, because combined with the long incubation period and not having any symptoms while you're out there, it's very concerning. Now, I do want to talk a little bit about asymptomatic versus pre-symptomatic COVID. Asymptomatic COVID means that you never develop any symptoms, ever. No symptoms, none whatsoever. And the degree of infectiousness is under debate. Some people think they still infect others, and others think it's not so much, because many people believe that what we're calling asymptomatic is really pre-symptomatic, which is actually more common than asymptomatic or never ever having one single symptom. Being pre-symptomatic is actually the peak infectiousness time, but the symptoms that may develop may be very mild. They may be simply some body aches or fatigue or sniffles. In fact, a doctor told me that if he had a dime for every person who thought their COVID was their allergy symptoms, right? I mean, it was something very, very mild, but it turned out to be symptomatic for COVID. But we just tend to label it all under the term asymptomatic. So just be aware of that. We definitely began to realize it was a problem when we started looking at crowded indoor places. And of course, the very first places we started being concerned about were the nursing homes and assisted living facilities, with stories coming out of Washington State. But many people chalk that up to frail old people being at risk. Then we started to see meatpacking plants. And we, of course, we saw prisons. And then we basically just started to see any place that was crowded, whether it was working or other place. And we realized that these were super spreader places, super spreader events. That term came into our lexicon because super spreader events typically involve indoor gatherings with many people, like weddings and funerals and church services and restaurants and work environments, exercise classes, etc. can all be super spreader locations. In fact, new research is finding that only about 10 to 20% of infected people are responsible for about 80% of cases. And so that's why you've started to see public health guidance coming out about the 3 C's: avoiding close contact, crowded places, being in closed spaces, and some people actually add on, and I think this is important, continuous exposure, the time element. And we're going to talk about that too in a little bit. But these are some studies that started having people really, really think, and these have become very famous studies at this point. These will definitely go down into the epidemiology literature as being pivotal studies. This is an indoor church choir. You probably heard about this. This church choir met on March 10th. Literally, that was the day, I think, when we all decided to not go to meet together in church anymore. So it was right at the very beginning. They had a 2.5-hour choir practice with 61 members. One person was sick with a few days with mild cold symptoms. The median age of the choir was 69, and only 1/3 of them had pre-existing conditions. But the members were singing their hearts out. They avoided physical contact, because again, this was Washington, and Washington knew it was having cases, but they did stand less than 6 feet apart. They went on break together, snacked on some cookies and oranges, and at the end of choir practice, they put away their stacked chairs together when they were done. Unfortunately, 32 confirmed cases came out of that, as well as 20 probable cases. They developed their symptoms anywhere from 1 to 12 days after exposure, and unfortunately, 3 patients were hospitalized and 2 died. This is another famous study that is changing the way we think about infectiousness of this disease. This is from China, and it's a restaurant, and this shows, this here up here is the entire restaurant floor, and then down here is a blow-up of the top tables, A, B, C, D, E, and F. And in table A, you see patient A1, who's the index case. This was an asymptomatic, probably pre-symptomatic patient or person who had a leisurely 1.5 hour dinner with 9 friends. And the red circles indicate people who wound up getting sick after this restaurant dining night. Now, the people around his table certainly are not that surprising, but you look at table B and 3 people got infected there, and table C, 2 people got infected there. Nobody got infected at E and F. The tables these are more than 6 feet apart. And what they realized is this air conditioner was blowing right straight through C, A, and B. It's not bringing in any fresh air. It's just, circulating air around. And so the turbulence comes back to table C. And that is the way they're surmising that this got transmitted. This is another study. This one is out of South Korea and shows you the impact in an office setting where people are sitting crowded together. This was over a week. You had 94 of 216 employees on the 11th floor in a South Korean call center. All the blue chairs are those that got infected, mostly on one side of this office. Estimates were that the vast majority, 94% of these infections, were from respiratory droplets or respiratory exposure. And we're going to talk about that in a minute. Minority of cases, about 6%, were from touching door handles, water coolers, elevator buttons, things like that. You had a few people on the other side here. So we definitely are pretty confident that this disease is very much spread by droplets. You have a person here who's infected, and if they sneeze or cough, their larger droplets can land in the mouths or noses, certainly of nearby people, or if he or she is sneezing or coughing into their hand and then shakes hand with a susceptible person, that direct contact will easily transfer those droplets. Droplets can also land on surfaces, like beds or again, door handles and things like that. That's called indirect contact. We don't think that's as big of an exposure as we might have thought several months back. It's still there. The risk is not zero. It's still important to clean surfaces and all, but this is nowhere near as important as respiratory droplets. And this up here, the small droplet nuclei, the ones that get aerosolized, are really where we are seeing a large amount of interest, and where we think that these super spreader indoor events are really where we're starting to realize that's how a lot of this transfer is happening, because we have found that that this coronavirus can circulate in air for a period of time up to 3 hours in an enclosed space where susceptible people can breathe it in. This is a ranking of viral load just based upon different things that we do. So you can see sneezing is the absolute worst. That'll blow out about 40,000 particles per sneeze. Coughing is about 710 particles. Then you have kind of in order of worse to better: singing, loud talking, quiet talking, and breathing, which actually puts out about 100 particles per minute. So breathing is still is putting out respiratory droplets. They're just not flying out as far as one sees with sneezing, coughing, singing, etc. This is a pictorial that shows you how an aerosol is generated. So the top one here on the left, this poor person is getting it all. Person B, person C doesn't get any exposure early on. But then you have those aerosolized particles that are beginning to just linger in the air. Person C still doesn't have any of that yet. But as time goes on, those aerosolized particles are going over to person C. Think about cologne mist in the air. You know, eventually it just kind of comes down and actually will settle on the ground. And what they've also found is that these surface particles, the ones that drop to the floor, are also at risk for resuspension into the air. So again, these are very, very tiny, less than 5 micrometer kinds of particles. And just so you know, size difference, a strand of hair is about 70 micrometers in diameter. So think about this going on, and now picture multiple people in a room just speaking and breathing all day, where the concentration of this aerosol is released just by speaking and breathing for more than 4 minutes, and that's equal to the concentration expelled for 30 seconds of singing or coughing. So time becomes really important in indoor spaces. And that's why you can look at the risk of infection as a function, almost like a mathematical function of viral load and exposure time. There's no zero risk. It's always going to be above zero, but it's a function of viral load and exposure time. And you can look at some examples here. If time is constant and you're 6 feet from an infected person who's sneezing or coughing, that makes sense that that's a greater risk than being 6 feet from someone talking and breathing. If time is held constant, being in a public indoor space is a greater risk than being in a public outdoor space. We have literally not seen one super spreader event that has occurred in an outdoor space. All right, you can see cases occur. You will see cases come about, a couple of cases, but you will not see 10, 15, 20, 30, 40 cases coming out of going to the beach. Or we haven't seen it coming out of the protests, for example. Granted, many people were wearing masks, but many people weren't. But that is just not the kind of event that we're seeing these super spreader events. If time is held constant and you're in an unventilated public indoor space, that's a greater risk than being in a public indoor space with circulating fresh air, right? So being in a public bathroom that's not ventilated with circulating fresh air is a much higher risk than one that has it. If time is held constant, being in a small public indoor space with 20 people is a greater risk than being in a large public indoor space with 20 people. This is just a dilution factor of the aerosol. Being in Publix with 20 people is less risky than being in a small meeting room with 20 people. Spending hours in a public indoor space is a greater risk than spending minutes in that same public indoor space. So when you have to go into a risky or what could be a risky public indoor space, don't spend a lot of time in there and keep chit chat to a minimum. Let's look at Florida cases. This is today, almost 380,000 cases in Florida. And many people for a long time when we were going through April and May, we're very happy because our test positivity rate was less than 5%. When I gave this talk a couple months ago, I basically was telling people we're actually doing okay. And the testing was going up, you know, at the time. So it wasn't increased testing that was the problem, and it's not increased testing now that's the problem. Now we see our test positivity rate almost near 20% for a while, a week or two ago. So if you extrapolate that to the community, that's like 1 out of 5 people you're meeting up with in the community could be positive. So we've clearly had a major community transmission going on around since June 8th. And we need to get this positivity rate back down under 5% before we can, certainly under 10%, but definitely back under 5% where things were much better for a long time. How do we know it's not just testing that's the issue? Because just testing won't cause this elevation in our hospitalization rate. And again, this is today's numbers, and you can see that the rate is just going up. And the fatality trend going up. This is today's numbers. Now, I do want to give you some good news because I do think there is some good news on the horizon. One of the things we look at is surveillance information. And I think probably Governor DeSantis is looking at this too, because he does talk about the fact that he thinks things are plateauing. And that's because our emergency rooms report back people who show up in the emergency room with symptoms, and they follow people who show up with cough, fever, shortness of breath, essentially the triad most common with COVID. And you can see this was March. We had a peak there. We came way down. We started going up again in June, and we've had a peak end of June, early July. But look what's happening here. It's possible it may be coming down. We might have peaked in early July, and it might be coming down. We're not seeing that yet in cases. This is simply, and we're certainly not seeing it yet in hospitalizations and fatalities because all of that is lagging. But this is more current information than the case report data that we get. And this shows in Florida how the 19 to 50-year-old population is what really drove the increase when those bars were opened and all that stuff. And this is our case trend as of today. This is today's date. And you can see it's possible we're coming down. We really need another week or two to know for sure, but it is possible we've hit a peak and we're starting to come down. Maybe because of bars closing, maybe because more people are paying attention to masking. It's hard to know, but we'll have to keep an eye on it. But it could be good news. Now, this is Escambia County, and this stuff is all off the Department of Health website. So if you're interested in following your own data, this comes from the Department of Health County report, and it's got some good information. You see that Escambia County had 6,300 cases today, was reported today, so this is today's numbers. 210 cases were reported over the last 24 hours. The average, or I'm sorry, the median age is 38. That number has gone up over the last month. We did see median age was in the 20s for a while, but now it's gone back up because the 20-year-olds definitely took it home to mom and dad and probably grandparents. Here's the hospitalization numbers, deaths, 1 new death in the last 24 hours compared to statewide numbers. Escambia, right at the beginning, Escambia had a problem with long-term care cases. That is still the case. You can see Escambia County is 9% of all cases, statewide 6%. So it definitely was more of an issue in Escambia County. This is Escambia County by age. Again, today's data, you can see primarily 15 to 34-year-olds drive the cases. Still, over the last 24 hours, 25 to 34-year-olds are 1/4 of the newest cases. Hospitalizations skew down towards the older ages, as do the deaths. This is Escambia County's dashboard. For those of you who don't know about it, you can easily find it. It's updated every day, and it's a very nice dashboard. Again, the total cases per day gives you your percent positivity rate in Escambia County, so it's above 10%. We want to see that back down under 5% if possible. It tells you your total hospital beds available and ICU beds. And you can toggle, you can see what does Baptist Hospital have versus West Florida, et cetera. So it's a very helpful, nice website. This is the surveillance data for Escambia County. Again, you can see the positivity rate here hanging around 12, 13% or so. Here's that triad of cough, fever, shortness of breath. It's a little bit messy. It's hard to tell exactly whether we're plateauing, but you sort of can get the idea that from June 8th or so, it went up, but there might be a little bit of a plateau there. So again, Escambia County may be plateauing. You know, it's hard to know. Don't look at these two because these haven't been updated. You can see the date there is more than a week and a half old. So those are old data there. So what can you do? I mean, it's overwhelming, isn't it? And about all I can say is listen to Dory and just keep swimming. Stick with the basics. Don't forget, if you have symptoms or a fever, please stay home. Remember that if you think you have allergies and you're an asymptomatic spreader and you don't know you're asymptomatic spreader, you can be spewing virus out there. Make sure you continue to practice frequent hand hygiene. Washing your hands with soap and water for at least 20 seconds kills the virus on contact. Using hand sanitizer with at least 60% alcohol contact. Make sure you let the sanitizer dry. That is what kills the virus. The desiccation on your hands is what kills the virus on your hands. And avoid touching your nose, eyes, mouth with unclean hands. If you need to sneeze or cough, do it in your elbow or into a tissue, but remember to throw the tissue away and immediately wash your hands or use hand sanitizer. And disinfect frequently touched surfaces. And there's a list of common EPA registered household disinfectants that will work. Social distancing was a term we didn't even know about 6 months ago. Now it's, again, part of our vocabulary. There really is nothing magical about 6 feet. So just keep that in mind, that you want to certainly try to be. I mean, a sneeze will go 20-some feet. So, you know, 6 feet, there's nothing magical, but it's a goal to try to stay away from somebody who's going to talk loudly in particular. Avoid the 3 C's, the closed indoor spaces, crowded places, close contact places, and avoid continuous exposure indoors. So I like to add that 4th C. General recommendations include high-risk groups should continue the most restrictive distancing guidelines. In general, don't go out, but if you have to, follow some basic rules and, for example, limit the number of indoor places that you visit in a day. Try to go to these places during off hours when they're less crowded. Again, try to limit time spent in public indoor places and limit chit chat. I have gone to the hair salon a couple of times during this pandemic, and my stylist, as well as her entire salon, wears masks. She's in Pensacola. That actually makes me feel better with the mandatory masking. I try to get a morning appointment first off, so there's no aerosols lingering in the air, and I tell her to keep her mouth shut. We really don't talk. I'm lucky because she doesn't like chit chat anyway, which I'm very happy about. So we limit the talking, and both of us are good with that. Leave unnecessary guests at home when you go out publicly. Try to get appointments so you're not standing in waiting rooms a long time. If you want to go to restaurants or public places, especially restaurants, make sure that they're enforcing safety protocols. Make sure that they're doing something to screen their employees for illness, that the employees are all wearing masks, that you see them disinfecting surfaces. I wouldn't give my business to places that don't do that. So don't touch publicly touched things. Magazines in particular, hopefully they've been taken away in a lot of waiting rooms, but even pens and papers. It's hard. I mean, I've had these things forced on me, and I'll wind up using a pen and then just reach for my sanitizer right after that and liberally dose my hands. But also bring disinfectant wipes with you. Put them in your purse or in your pocket, and don't hesitate to use them if you're sitting in a chair in a public waiting room, like in the medical office or something. Just wipe down those arms. By all means, wear a face mask. Make sure the mask covers your nose and mouth. Makes me nuts when I see people whose mask is below their nose. As you probably heard a lot about recently, masks do prevent 99% of large droplets from escaping from you, and it protects other people from those large droplets in case you're an asymptomatic spreader or a loud talker. And the CDC states that if 80% of the population wore masks we could reduce the COVID spread in half. Now, what protects, so this protects other people. You've heard that my mask protects you, your mask protects me, and that's very, very true. However, aerosolized particles do escape from masks, and really the only mask that protects you from 95% of particles is the N95. The problem is that we don't have access to N95 if we're not healthcare workers. And this kind of PPE is at a premium. So we wear our cloth masks and we wear, these paper kinds of masks. And that's why it's important that everybody wear the masks, because if you go into a room wearing your mask and most people are not wearing their mask, you're really not being protected. So even though you're wearing the mask. Also, avoid people who wear masks with vents or valves. That's really, they're fine wearing the mask, but again, the valve puts virus out there. So that's not a good mask to wear. Don't forget to optimize your immune system during this time so that you're the healthiest you can be. Continue to get exercise, especially outdoors. Being outdoors, taking walks is just about the best thing you can do for your mind and body. Eat a healthy diet, maintain a healthy weight. This is not, it's hard. Putting on 20 pounds is not hard during this pandemic, but do what you can to avoid that. Stop smoking if you are a smoker, and avoid excess alcohol. This is where many Zoom happy hours could get us into trouble, but just limit things in moderation. Don't forget to get your flu shot this fall. A flu shot's not going to protect you from COVID, and it will not prevent you from spreading COVID if you have it. But without a flu shot, you are much more susceptible to getting the flu, which will increase your risk of being immune suppressed, developing pneumonia, and being susceptible to COVID infection and complications if you get COVID. The good news is that with all the hand washing and sanitizing we're doing, we'll hopefully keep influenza down as well, but don't forget your flu shot. What about testing? PCR testing or antigen testing tests for active infection. It tests you at that moment, whether you're infected. It doesn't tell you if you were infected, weeks ago, because it won't be there anymore. And it doesn't tell you if you're immune to COVID. Also, there is a very high false negative rate within the first 5 days of exposure. Using these nasal swabs, 20% of infected people even still test negative 3 days after symptoms. So clearly we need a better viral test. It's the only thing we've got, but just realize that there are false negatives with this test. Some neighbors of mine, I moved here from Cincinnati 12 years ago, and my neighbor across the street, unfortunately, was in the ICU. He's still struggling mightily to recover. His wife got infected, and his 30-year-old son living with them got infected or got symptomatic, diagnosed with pneumonia, mother positive, father in the ICU, and he was told he didn't have COVID, because his test was negative. Now, the test was a false negative, almost certainly. There's no way a young, healthy person is going to get pneumonia during a pandemic living in a house with 2 people with COVID. So certainly he had COVID, he just didn't test positive. Now, if you have COVID symptoms or have had exposure to it, get PCR tested, self-quarantine while waiting for your results, get advice from your physician about when to seek emergency care or medical care if you're symptomatic. If you have no symptoms and you've been exposed, wait to get tested about 5 days after exposure, based upon what we know about the false negative rates. You can get tested, as you know, at many community sites, even without history of exposure or symptoms. The problem now with the peak that we've had over the past month, the lines are long again. The waiting time to get the results is horrendous. It's almost not helpful right now. Once we bring this peak down, hopefully, then going in and seeing if you're an asymptomatic patient will be good. Of course, there is serology testing out there. It is a blood test, and it could be helpful if you believe you've had COVID but were never tested, or you've had a COVID test and were negative and you're pretty sure you had it. So ask your doctor or call the health department about the availability, because all of the sites that you see advertised for doing COVID testing, they're all doing the PCR testing, but you can get the antibody testing in some places, I'm pretty sure, because I've seen results of antibody testing for Florida regarding where we stand. The antibodies that develop after COVID that they look for are IgM. Those last for about 2 weeks after infection, and IgG, that comes up more slowly over about 4 weeks and lasts longer. Of course, we're seeing now, we don't know how long will the antibodies last. If the antibodies go away, are you at risk for another case of COVID? Very concerning questions, but some recent studies do point to the fact that we should be reassured that even though we might not be able to see the COVID antibodies when we test for it, our immune systems are very complicated systems and have immune memories that basically if we come up against this virus again and we've had COVID, almost certainly we'll be able to fight the infection by bringing out our T fighter cells to do the fighting. Also, if you're interested in knowing if you have antibodies, Red Cross is now testing all blood donors, so you can kill 2 birds with 1 stone. You can donate blood as well as find out if you have antibodies. While we're on the subject of antibodies, I do want to talk a little bit about herd immunity so that you understand it. This is a population without herd immunity, right? You have this infected person, all the people are susceptible, and this person is infecting this person who's then infecting that person. This is kind of where we are right now. No herd immunity. Herd immunity is when you have people who are now, a lot of people who are now immune, and when you have an infected person, they're gonna, and there are few susceptible people, you have all these immune people protecting the susceptible people from getting infected. See, they're kind of in the way. So these people are safe from being infected from this person. So that's herd immunity. And in fact, that's what protects some people who don't go out and like to get vaccinations for their children are actually protected by all the children who get vaccinations because we have herd immunity. Now, herd immunity for COVID, we assume it's about 40 to 70% is what we need for our society or population to have this kind of herd immunity protection. We're only at 4%. So when you hear people talk about, let's just everybody get infected and we'll all get to herd immunity, no. We're a long, long way from herd immunity and we won't reach it really until a vaccine is available, hopefully in mid-2021. This is a model of where we probably will be in November. And it's not pleasant, but it's just reality. And I told you I would just tell the truth because I prefer that. But here we are today, right? We've had 5,200 deaths in Florida as of today. And this model is projecting out about 19,000 deaths if mandates ease. So if DeSantis comes along again and starts opening up bars, if that peak comes down and just starts opening things up more, they're projecting 19,000 deaths by November 1st. If we have universal masking, which I don't see him doing, they're projecting 12,000 deaths. But because of all the businesses who are mandating masks, I'm just going to say, let's assume we're somewhere in between here. Okay, let's assume 16,000 deaths by November 1st. Keep in mind, we're at 5,200 right now. Now, this is the percentage of deaths and the age group we would expect to see with 16,000 deaths in ages 5 to 14. We would expect 8 deaths in Florida. Currently, we already have 3 deaths of children aged 5 to 14, but we would expect to see more. About 0.25% of deaths occur in our high school, college age students. We would expect to see a total of about 38 deaths by November 1st. We already have 13 deaths in that area. I don't know about you, but you know, a lot of parents don't want to risk their children to be one of these 8 deaths or one of these 38 deaths. 3% of deaths occur in young adults, the parents of these children. We've already had 480 deaths there, or I'm sorry, we expect 480 deaths by November 1st. We currently have 154. So we expect 480 young parents of these children to die by November 1st. And then of course the numbers go up with age group, 45 to 64-year-old age group, which is our peak working people. We've already had 2,000 deaths. Currently, we sit at 751. And of course, the age group that everybody wants to just dispose of and throw away, all of us over age 65, we've already had over 13,000 deaths, and we're projecting 13,000 deaths. We currently have over 4,000. So this is just Florida. So we need to continue doing what we're doing. You need to stay strong mentally, physically. Tell people we just can't afford for everybody to get sick and try to get to herd immunity. It will just kill too many people, including children and young adults. This will be in our rearview mirror someday, but not soon. It's just not around the corner. But be prepared to live your lives when we see credible new scientific evidence come along. So for example, wearing a mask, being around other people wearing masks does offer protection. It is almost like herd immunity when you're around everybody who's wearing masks, or even 80% of people. So I tell people, don't get upset if you don't see every single person not wearing a mask in a store. If 80%, 70, 80% of people are wearing masks, that is actually helping to protect most people. So, you know, let's not get too crazy and start fights and stuff like that, but definitely wearing masks is helpful. Do things outdoors. There's no reason you can't get together with neighbors and friends and sit outside socially distanced and use all the precautions necessary. That's no problem. But you just have to be careful. And finally, work to prevent a similar disaster occurring in the future like this. And how do you do that? You can do what I do. I channel my emotions into activism, and I plan on voting. I encourage all of you to vote. I encourage you to tell everybody to vote, because we need to restore a government that believes, again, in science and believes in pandemic preparedness. This did not have to happen. The pandemic was going to happen, but we did not have to have the disaster that we've seen unfold. We need to strive for justice and equality. And again, I'm preaching to the choir here. We need to elect principled government leadership with moral values that doesn't toss old people aside and really does value life. And we certainly need to fix our broken healthcare system, which currently is not working for people, and we're going to see more problems with it in the future unless we figure out how to give everybody the health care they deserve. And that's it. And with that, I will stop sharing and take questions from you.